Hello, everyone. I hope you and your dear ones are all safe and healthy. I hope also that you have good connection and can see and hear us well. Welcome to the Columbia University webinar, COVID-19, Migration and Human Rights, Impact and Solutions, organized by Columbia University's Institute for the Study of Human Rights. I am Dr. Gianna Sanchez Moretti, your facilitator for this webinar within the framework of the Institute's virtual workshop on migration and human rights, a virtual workshop part of the Human Rights and Social Justice training series. For more information about this training series, please check out the link in the chat below. The Institute's trainings address thematic issues and practical skills and are intended to enhance the work of human rights and social justice professionals and students. This live expert panel is a special session open to the public and is part of Module 2 of COVID-19, Migration and Human Rights of our virtual training workshop. For more information about this topic in particular, please check out a special podcast episode through the link in the chat below. I hope you can all see the links. I will pass them here again for you. There you go. During today's webinar, we will discuss and explore who are the migrant populations at risk of being left furthest behind, how the human rights framework for the protection of migrants is a fundamental pillar in responding to and recovering from the impacts of COVID-19, and examples on the ground of actual responses to COVID-19 emergency from migrant and refugee populations, challenges and solutions implemented by various actors. A big thank you to all of those that contributed in making this webinar happen. Our panelists today are Monette Zard, Associate Professor of Forced Migration and Health, Population and Family Health, and Director of the Program on Forced Migration and Health at Columbia University's Medical Center. Felipe González Morales, the United Nations Special Rapporteur on the Human Rights of Migrants and Director and Professor of the Master in International Human Rights Law at La Universidad Diego Portales in Chile. Rohini Deshmukh, External Relations Officer at the United Nations High Commissioner for Refugees. Francisco Alfonzo, Associate Human Rights Officer at the United Nations Human Rights Office. Roberta Petrucci, Medical Coordinator for COVID-19 response in Switzerland for Doctors Without Borders. And Andrés Boscán, Vice President of Asociación Salto Ángel, a diaspora-led migrant NGO in Colombia supporting the Venezuelan migrant population in the border migration hotspot. Panelists will have 8 minutes to present, and we will also have 30 minutes question and answer session in the end. This webinar will be recorded and will become available thereafter. Thank you all again for being here with us today. I'd now like to kindly request just 30 seconds of silence for the millions of people that have fallen victims to COVID-19, those in the front lines, and those who have been severely and detrimentally affected by this emergency crisis. Thank you very much. Without further ado, as we all are looking forward to the contributions from our experts today, the first question goes to Professor Monette Zard. Professor, from the migrant populations, who, how, and in which situations are the most vulnerable? Who is at risk of being left furthest behind and why? And which are the main human rights principles for a COVID response specifically concerning migrant populations that can help mitigate these risks and human rights gaps? Over to you, Professor Monette Zard.
Thank you very much, and thank you to the Institute for the kind invitation to participate today in this important panel. I have 3 big questions to answer in 8 minutes, so I will get on with it without further ado. And beginning with this first question about points of vulnerability for migrant populations, I'd like to flag 3 key human rights challenges that I see. First of all is the issue of mobility rights. As the world grapples with the COVID pandemic, more than 190 countries have imposed COVID-19 related travel restrictions, and 3 billion people have ended up living in countries that have completely shut their borders to refugees, asylum seekers, migrants, and foreigners in general. Migration, not surprisingly, is down as a result, but it has not stopped. People still continue to move, and they move for the complex reasons that migrants and asylum seekers have always moved, and the stark reality that conflicts and persecution don't stop for pandemics. So this has led to particular concerns for asylum seekers, refugees, migrants who are ended up stranded by the lockdown and in border regions as states close their borders. So in the Sahel, for example, over 20,000 migrants have been stranded at borders, and close to another 2,000 are in transit centers. And aid organizations in Niger are just reporting being overwhelmed by requests for assistance. There are also particular challenges for migrants and asylum seekers stranded at sea, as countries basically refuse permission to disembark. So for example, in the period between May to early June, the Malaysian government reported pushing back 22 vessels containing Rohingya refugees using COVID-19 as an excuse. And we know that refugees have died of exposure and starvation as a result. In the Mediterranean, Italy and Malta have further restricted the operation of rescue ships, making the crossing of the Mediterranean even more deadly than usual. And then finally, migrants trying to return home have also found themselves on the receiving end of problematic measures from their own governments. So in Nepal, the court ordered the government to pay for the cost of the evacuation of citizens who couldn't afford to fly home, but the court also had to order the government to actually allow migrants to come back home, as it had banned them for up to a year, again, citing COVID as a reason. The second challenge that I'd like to raise today relates to stigma, racism, and xenophobia. From the earliest days of the COVID-19 pandemic, we've seen attempts by politicians to assign a nationality to the virus and attempt to scapegoat certain groups. And the tendency to blame foreigners or marginalized groups for disease has deep historical roots. You know, for example, the Irish were blamed for bringing cholera to the United States, the Italians for spreading polio. Trump's attempts to label COVID-19 the Chinese virus has fueled violence against people of Asian descent, certainly in the US. And there have been many examples of stigma and xenophobic violence during the current pandemic, which the UN Secretary General has described as a tsunami of hate. And there is something about the way that information and misinformation spreads and the speed at which it spreads today that I think has really amplified this problem. So for example, we see Hungary's Viktor Orbán seizing upon the crisis to suspend asylum, explicitly linking illegal immigration and the spread of the pandemic, of course, without any evidence. In Venezuela, returning migrants have been described as biological weapons. And in Yemen, we've seen roundups of thousands of Eritrean migrants by Houthi armed groups, who again have been blaming them for the spread of the virus without any kind of scientific basis. And we know that the first line of defense that we have in public health is people coming forward to disclose their symptoms for early diagnosis and treatment. And we have learned from other pandemics, from HIV, from Ebola, that stigmatizing viral transmission only further places populations at risk because it pushes them even further into the shadows. So effectively tackling this pandemic requires strategies to engage with and stop stigma. The third issue and final issue that I wanted to raise in terms of the migrant vulnerabilities are the particular challenges around access to treatment and care, which migrants and asylum seekers face, and inequitable access to testing and treatment. We know that particularly undocumented migrants have limited access to testing and care, and we know that many refugees and migrants are extremely susceptible to infection because of their living conditions in refugee camps or informal settlements, because of the poor nutrition that they have, and also because of the work that they do. So ensuring that they have comprehensive access to prevention as well as testing and treatment alongside other populations is absolutely critical. And this is especially important at a time when health resources are scarce, and we know that governments are likely to prioritize the interests of their own citizens. And the lockdown has also complicated issues with renewing documentation, which has pushed some migrants into an irregular status, and which in turn then also complicate accessing treatment and care. Finally, we know that for migrant populations to feel safe enough to come forward for treatment and for testing, that there needs to be clear firewalls between health provision and immigration enforcement. One country leading by example has been Portugal, which has granted non-citizens equal rights to healthcare during the course of the pandemic, and there are others as well. But even in places where migrants on paper may have access to healthcare on an equitable basis, we know that discrimination and stigma get in the way of accessing that treatment. So I think it's really important to bear that in mind. Now, moving on to your second question, as we look to the future and migrant populations that may be left further behind, I think some of these challenges around equitable access to healthcare, stigma, and discrimination will undoubtedly play out also when we think about access to a future vaccine and to effective therapeutics. And the nationalism, which has so far characterized much of the discourse and action in this area, does not generate much hope on my part that vulnerable groups, and in particular migrants and displaced populations, will have a fair opportunity to benefit from vaccines or therapeutics. Moreover, as states start to open their borders, we see, I think, some conversations happening that also give rise to concern. So mobility corridors are being discussed, for example, between bilateral and regional countries that build on some of these emergency air bridges established early on to repatriate nationals. And it's not clear where refugees and asylum seekers are going to fit in this new scheme. The other thing I think that will raise some questions are the new health checks and hurdles that travelers will undoubtedly have to undergo. And we see conversation about things like immunity passports, which have a very questionable scientific and ethical basis, which I think will also complicate issues for migrants and displaced populations. And to paraphrase Antonio Vitorino, the head of the IOM, health is the new wealth, and it will be the new game changer in town. If the current pandemic leads to a 2- or even 3-tier mobility system, then we will have tried to solve the pandemic, but at the same time, we will have deepened inequalities. Just very briefly, the third issue, some of the legal principles that might help. I'd like to point you to 14 legal principles on the protection of migrants and refugees and displaced populations that were put out by the Program on Forced Migration and Health, the Zolberg Institute on Migration and Mobility, and the Cornell Program on Migration and Human Rights, which have been now signed by nearly 1,000 legal scholars and migration scholars. And you can find them on the Zolberg Institute website. But obviously, I would flag for your consideration norms around equal treatment and non-discrimination, rights to health, which are absolutely critical. And as we think about the lockdown, understanding that the right to health incorporates things like access to food, water, sanitation, shelter, and so on. Of course, the principle of non-refoulement, or non-return and access to territory, which is absolutely critical, and which I think we'll discuss quite a bit in this panel. I won't dwell on it more, but just to say that blanket bans of the kinds that we're seeing are absolutely unacceptable from a human rights perspective. And then finally, obligations to combat stigma, racism, and xenophobia, along with the right to information, which is absolutely key for both ensuring the right to health and combating stigma. So in conclusion, I'd like to say that if this pandemic has done nothing else, it has made visible the reality that our health is interlinked, and the health of all of us rests on ensuring that even those who are most marginalized in society also have access to the right to health. It cannot be an either or. We have to lift up all boats at the same time to ensure that everyone has access to testing and treatment. And that is as much a human rights challenge as it is a public health challenge. Thanks very much, and sorry for going over time.
Thank you so much, Professor, for that incredible insight related to the human rights gaps and challenges that we are now facing for vulnerable migrant populations around the world. Thanks for giving those examples and then zooming into those principles anchored in human rights law and the human rights principles to be able to find solutions. So, thank you for that. And now I pass the word to the Special Rapporteur, Felipe González Morales. Your question for today is, how is the human rights framework for the protection of migrants a fundamental pillar to respond to recover from, and to prevent such emergency situations such as the one posed by COVID-19? In your work observing state responses in relation to the protection of the human rights of migrants during COVID, can you share maybe one or two examples that seem to be promising practices that you have observed and can encourage? Over to you, Felipe. Thank you very much.
Thank you very much, Gianna. Thank you for the invitation from the Institute for Study of Human Rights at Columbia University and for the public attending this, this webinar. My mandate, along with the Committee on Migrant Workers, issued a couple of months ago a joint guidance note to states calling to fulfill their obligations on human rights regarding migrants during the pandemic. In fact, I would say that most of the key features that have become more acute during the pandemic regarding the situation of the human rights of migrants are the consequence of bad policies that were in place before the pandemic. So you can see how in those countries which had bad migratory policies before the pandemic, this situation became much worse now, while in other countries which had in place before the pandemic good policies or policies that protect the human rights of migrants, they can deal better with the situation of migrants during the current situation, the current context. Now, at this joint guidance note that we issued, we call on states to ensure that emergency powers do not overcome the, do not override the rights of the migrant population, either regular or irregular migrants. And this, of course, affects the entire population. But in the case of migrants, because of their special vulnerability and invisibility, these emergency powers, when they are not adequately used, have a bigger, more grave impact. There are a number of aspects that I think are relevant to the question that was, the first question that was presented to me. One, I think it's important, is the issue of the integration and inclusion of migrants in the host countries. Of course, this is a feature that should be present at all times, not only at the pandemic, but it becomes much more needed at this time to avoid stigmatization and criminalization of migrants, especially in those who are in an irregular situation. Secondly, there is the issue of establishing adequate policies of regularization. We have made calls, my mandate, the Committee on Migrant Workers and other human rights bodies at the international level, we have made repeated calls to states to undertake adequate processes of regularization in normal times. And this becomes much more needed now at the situation of the pandemic, especially in those countries where the legislation doesn't have in place good rules for the protection of the human rights of the migrant population, especially the irregular one. So I think this should be a key aspect that should be enhanced from the point of view of a human rights approach toward migration. Then there is the issue of access to public services, particularly the right to health, as the previous speaker was stressing, and also the need to establish strong firewalls between the public services and the migratory agencies. So people can go to the hospital or to a tribunal or to other public service, sure that he or she would not be detained or deported as a result of that action. Then there are the issues of the standards of return. On return, the non-refoulement principle. In this regard, unfortunately, there have been states, including the United States, that have been deporting people even with COVID-19 without really taking appropriate measures. I think that returning people at this current acute situation is really problematic. And I think that those states which have remained doing that are in many occasions violating the human rights of the migrants. There are also issues regarding the countries of origin. In this regard, I would stress the need for strong reintegration programs. This is a matter that my mandate addressed in a thematic report a couple of years ago. And unfortunately, it's a matter that has not been addressed really by most countries. When migrants return forcibly or voluntarily to their countries of origin, they have in place appropriate programs on reintegration. I have seen this in many of my official visits. I saw this in Niger, in Nepal, where there weren't such programs. In the case of Niger, for instance, it receives a huge amount of contributions from the European Union, but this is mainly for security purposes, really, not to establish, for instance, reintegration programs or public services stronger for not only for the Nigerians, but also for people from other African countries who have been deported to Niger. And this is true also in the countries of Latin America, and most of them at least. So that's another point that is relevant at all times, but becomes more acute in the current context. There is the issue of the respect of the right to seek asylum that I imagine it's going to be addressed by the representative from UNHCR, that unfortunately is also under severe restrictions nowadays, although it is not a right that can be suspended according to international law. There are also the need to enhance the monitoring of the situation of the migrants by the civil society, and the civil society has the right, every individual and the civil society organized has the right to get access to public information on the situation of migrants. Unfortunately, this is also a right that has been severely limited during the pandemic in many countries. And then there is the right to organize by the migrants themselves and their defenders, as I have stressed in my report presented a couple of weeks ago to the Human Rights Council of the United Nations. Now, concerning good practices, I would like to mention, for instance, the full access to health that migrants, either regular or irregular, have in Spain. In some other countries, such as in Portugal, a temporary resident permit has been issued for migrants to achieve this objective. But you can see a difference, because in one country, in Spain, this was already in place. It didn't need a special measure. While in Portugal, this required an additional measure, which was a good one to be sure, to achieve the same objective. But this should be a permanent policy, the access to universal health by all migrants, not only for the pandemic. Another good practice has been the release of many migrants and asylum seekers from detention in many countries around the world. Being locked is, of course, a risk for their health and their life, and also for public health, being in detention. And I think that this should be taken as an opportunity to ensure that detention of migrants becomes really a measure of last resort. This has been repeatedly stated by many international organizations. It is now in the Global Compact on Migration, and I think that this is an opportunity to really move forward in this regard. And finally, regarding also the issue of detention, the detention of migrant children. This has been repeatedly also addressed by international bodies, including mandate, that is in violation. This practice is a violation of international law. And I also consider that this is a good opportunity to end definitely with this practice around the world. Thank you very much.
Muchas gracias, Relator. Thank you very much for your intervention and for sharing on the human rights principles and challenges as well, and those examples of actions and engagement that promote and protect the human rights of migrants, even during COVID times, in line with international human rights law. Now, we all know that the UN Refugee Agency is one of the most important global actors in responding to serious humanitarian situations, such as this pandemic, to protect refugees and their rights. Now, let's take a look at how the United Nations Refugee Agency has been responding to the impact of COVID-19 for refugee populations and some examples from the Asian region. Rohini, over to you. Thank you very much.
Thank you, Gianna. I'll try to be brief, although I have quite a bit to cover. So just to provide a quick overview of what UNHCR has been doing to respond to the COVID situation and the challenges that we have faced along the way. As you know, following the declaration of the pandemic by WHO on 11th March, UNHCR has been scaling up its response in all countries with persons of concern, with particular attention given to situations where the pandemic is, if you may call it, an emergency on top of an emergency in countries such as Bangladesh, DRC, Iraq, the Sahel, South Sudan, Syria, Yemen, and the Venezuela situation. There are 134 refugee hosting countries which have reported local transmissions of COVID. As you know, 71 million forcibly displaced persons worldwide exist, and about 80% of the world's refugee population and almost nearly all IDPs are hosted in low to middle income countries, which have weak health, most of which have weak health sanitation systems. 3/4 of the refugees are living in overcrowded camps and settlements, as well as in reception centers in urban areas where they lack access to adequate healthcare and sanitation. So UNHCR's primary goal, therefore, has been to ensure that all measures are taken to align the rights and the needs of refugees and host communities, and that all persons of concern are included in the national COVID-19 surveillance, preparedness, and response planning activities in coordination with the relevant ministries of health and the WHO. UNHCR, through its multi-sectoral partnerships, has focused on 4 priorities to address this pandemic, which is, the first is health, water, sanitation, and hygiene. Second is cash assistance, shelter, core relief items. Third is protection and risk communication. And lastly, education. So to move on quickly, we have issued guidelines along with IFRC, IOM, and WHO on delivering humanitarian assistance in camps in the current situation. In addition, we've been engaged in monitoring preparedness and contingency planning right from the beginning of the outbreak of the pandemic, particularly in countries hosting large refugee populations and with weaker health systems. Very briefly, in terms of preparedness activities, UNHCR has been supporting governments with provision of various medical equipment, personal protective equipment for health workers, training staff, assessing needs of medical equipment, isolation facilities, providing mental health psychosocial support through community networks, as well as creating materials, awareness-raising materials in multiple formats, just audio, online, written materials for mass distribution, in appropriate languages for the persons of concern. We're also addressing the practical needs where we have disrupted supply chains around the world, which is making the challenges of bringing essential medical, sanitation, and other supplies to those in need. We've been using humanitarian air bridges, humanitarian exemptions as solutions, and we've had 2 airlifts to Iran with emergency medical aid for refugees and host communities, which has proven very effective. We're also at the moment trying to secure humanitarian exemptions with governments to enable our staff and partners to be physically present closer to our persons of concern in providing protection and assistance. We have also recently launched a publicly available platform for the protection impact of temporary measures in response to the COVID-19. This is a temporary tool to inform states, donors, and partners during the pandemic and to identify protection needs. So the data is publicly available, and UNHCR is, through this data, better able to ensure that states have the support they need, both to respond to the health crisis as well as to meet their protection obligations. The numbers of infections with refugees and asylum seekers has been increasing. In Asia, some host country governments have ensured that persons of concern have free access to COVID testing and treatment. For example, Iran is an example where over 1 million Afghans are included in the national health services and healthcare system and have access to such provisions. In other countries, UNHCR is working together with the governments to be able to access testing and treatment. We have been providing them with testing kits, like in Myanmar, for example, in Bangladesh, in Afghanistan and Pakistan. Also, public health capacity in host countries, mostly in Asia, remains minimal, with hospitals and clinics reporting challenges, as well as an ability to maintain or expand their capacity to treat patients with COVID-19. So there are also, practical solutions of provision. We've had, for example, in Bangladesh and Cox's Bazar, we've built 4 quarantine centers. We are running 2 isolation treatment centers. We're also expanding the ICU capacity in one of the hospitals, which is then for the benefit of refugees as well as the host communities. The struggle for survival for refugees has intensified, as you know, due to the containment measures. 70% of refugees live in countries with restricted right to work, and 95% are self-employed. 50% of them are employed on a daily or a weekly basis in informal work sectors, which, as you know, also have been severely affected. So UNHCR has been undertaking cash-based incentives, which has been sort of the core of its global and regional response to the COVID pandemic. And especially in Asia, we've had about 11 country operations using the country-based, cash-based interventions, which is a quick and an efficient means to provide people in need with support, thereby empowering families to make the best decisions on how they can take care of themselves. Now, the response initially has been focused on basic needs, and now we're looking at medium to long-term assistance for livelihoods, given that the crisis will remain with us for some time. Moving on to protection concerns, they have increased. Governments around the world are adopting increasingly stringent measures to protect public health, and while doing so, fundamental principles of refugee and human rights law are also being challenged. UNHCR has been advocating with states to ensure access to asylum while also protecting public health. While states may temporarily close their borders to limit COVID-19 transmissions, asylum seekers also have a right to seek international protection at those borders, and that they may not be returned either directly or indirectly to a country of persecution or danger. UNHCR estimates to have about 123 countries that have fully or partially closed their borders to contain the spread of the virus, with about 30 states making no exceptions for access for asylum seekers. Many have suspended the right to seek asylum. A number of refoulements have been reported in many regions. The challenge UNHCR faces is to strike a balance between these obligations. However, states do have options. For example, impose measures at the border such as health screenings, testing, quarantine, self-isolation to manage the health risks of asylum seekers while also respecting the principle of non-refoulement. The pandemic has also been challenging for many countries that receive asylum seekers and to assess their claims for protection. UNHCR is advocating for reception of asylum seekers and processing of asylum claims to continue with the priority for the most vulnerable. Technology can be used, for example, remote interviewing, case processing where health restrictions prohibit face-to-face interviews, and this is something that we've been using as well. Other protection measures, such as automatically extending national registration cards of refugees in host countries, extending residency permits to enable refugees and asylum seekers to access health and other services, is something that we've been actively advocating for. Quarantine measures may be a legitimate restriction on freedom of movement temporarily. However, health concerns do not, for example, justify the systematic or arbitrary use of immigration detention. There's also risk that temporary restrictions on the exercise of rights to respond to the virus can be maintained long after they are needed, diminishing the respect for international refugee and human rights norms and the fundamental rights to protection. Finally, the closure of schools worldwide has dramatically impeded the right to education of refugee children. Children are especially vulnerable to exploitation through child labor, trafficking, early child marriages. UNHCR is engaged also in special efforts to ensure the protection of children where families face economic stresses. So this is sort of, in a nutshell, what we have been doing globally to address the COVID pandemic for our persons of concern. I do have more examples, but perhaps that will come up later in discussions. Thank you.
Thank you so much, Rohini. Thank you very much for these insights on how UNHCR is playing a very important role globally to promote and protect the human rights of refugees and other migrant populations during these critical times, and examples of that response in Asia, especially in critical settings such as in refugee camps. Now, let's take a look at another important aspect of human rights and migration, which concerns the right to liberty and security of migrants, a right that is very often at risk in the face of detention practices in the context of migration, and also threatened and further aggravated by a health emergency, which also impacts the human rights of migrants to the enjoyment of the highest attainable standard of physical and mental health. Here with us today is Francisco Alfonzo, Associate Human Rights Officer, supporting the mandate of the United Nations Working Group on Arbitrary Detention. The working group recently adopted a deliberation on prevention of arbitrary deprivation of liberty in the context of public health emergency, deliberation number 11. Francisco, during these times of COVID-19, what are the key human rights principles and implications of the working group's deliberation number 11 for migrant populations? Could you share with us some examples of its implementation? Thank you very much.
Yes, thank you, Gianna, and the organizers for the invitation, and also to the audience for their interest in this event. To give a little bit of context about the question on deliberation number 11, I would like to explain first what is a deliberation. The Working Group on Arbitrary Detention has almost 30 years investigating individual cases of arbitrary detention mandated by the Human Rights Council. And during those investigations, the Working Group has been applying key principles and key rules and key criteria to identify when a detention is arbitrary or not, and to assess all of those cases. So from time to time, the working groups make a stop and reviews the case law that it has developed and the criteria that it has applied during the investigation of these individual cases, and comes up with these deliberations, they are called, where it summarizes the key principles and criteria that it has applied to the cases on a particular topic or issue. For instance, in this case, public emergencies, but also migration. And recently, the working group has done both. 2 years ago, it approved and adopted deliberation number 5, which is a revised deliberation because it was already issued a few years ago, but it updated it. Deliberation number 5 looks into the issue of detention of migrants. Then this year, in the context of the pandemic, the working group reviewed its jurisprudence on the topic of state of emergencies and in particular health emergencies, and came up with this deliberation 11, where it summarized the key or more important elements of depriving someone of his or her liberty during public health emergencies. So we cannot talk only about Deliberation 11 without considering also the revised Deliberation number 5, because also that it's relevant for this topic that we are addressing today. In any event, I would like to start saying that the most important and key principle on both deliberations and for all issues of detention is that detention should be exceptional, and detention should be a measure of last resort. Even though the right to liberty is not absolute, it could be subject to limitations. Arbitrary detention is prohibited, and the prohibition of arbitrary detention is absolute. So how do you do for a detention not to be arbitrary? Now, to start with Deliberation 11, Deliberation 11 states very clearly that a deprivation of liberty is a question of fact. It's not a question of law. So you need to see the facts at hand and determine if there is a deprivation of liberty or not, considering whether the individual is confined in a restricted place from which he or she is not able to leave. Then, once you have determined that you have a deprivation of liberty, Deliberation number 11 then looks into the issue of what's the legal basis for that deprivation of liberty, what has been the process to lead up to such deprivation of liberty, and also there needs to be a time. It cannot be indefinite, either in the context of migration or criminal justice system. It needs to be fixed time. It could not be indefinite. Now, any deprivation of liberty also needs to be necessary and proportional. And in the context of the current pandemic, and Deliberation number 11 says so, the circumstances of an individual detention may have changed, and therefore deprivation of liberty that was considered necessary and proportional last year may not be this year because of the heightened risk to the health of a person that is confined in an overcrowded place, for example. So the principles of necessity and proportionality of the deprivation of liberty are also addressed in Deliberation number 11 because the circumstances may change. So Deliberation 11 also requires and suggests that states conduct a review of that necessity and that proportionality to determine whether it's necessary to continue with the detention of the individual, again, independently of whether it's in the criminal justice system, of migration detention, or other forms of deprivation of liberty, which could include, for example, drug rehabilitation or psychiatric detention, etc. Now, we also need to consider that Deliberation 11 says that COVID-19 poses a particular risk for key groups of people, for example, people over the age of 16, or pregnant women, or people with disabilities. Now, Deliberation number 11 does not say that migrants are part of this vulnerable group, but that's a good question for debate. Shall we consider migrants as also a group of under a particular vulnerability that needs to be protected? Interesting question for discussion. Now, also we need to consider that during the current pandemic, many places of detention suffer from overcrowding or poor hygiene, and that's another relevant element that suggests, and Deliberation number 11 asks or invites governments to review each individual case, also with a view of releasing individuals to reduce overcrowding and to ease the access to healthcare services and hygiene, particularly in the cases of those who are detained or deprived of their liberty for non-violent offenses or for non-violent crimes. Now, moving on, Deliberation number 11 also requires that, irrespectively of the reasons for the deprivation of liberty or the context, people shall be guaranteed the right to challenge the legality of the detention and to go before a court of law to question whether that detention is legal or arbitrary or not. So that's another right, the right to challenge the legality of detention that cannot be suspended due to the public emergency. Now, the question that comes that follows is how do you guarantee that access to the justice system to challenge or question the legality of the detention during a situation of lockdown. And then deliberation number 11 also answers that states need to adopt or implement measures that would guarantee due process and that would guarantee and facilitate the communication of the individual deprived of his or her liberty with the lawyer, or also communication with the court, even if this is by electronic means, through correspondence, etc. Now, another important element that deliberation number 11 says is that the use of emergency powers cannot be discriminatory. And that's also another element where the migrant population becomes relevant. How can we make sure that migrants are not specifically targeted, or certain group of migrants, let's say migrants of certain religion? How states need to make sure that they do not discriminate against particular groups in this context, and that they don't use the pandemic situation and the emergency as an excuse for abusing those emergency powers. Also, just to conclude with deliberation number 11, it also, and very specifically in the chapter of migrants, or the section of migrants, it reiterates the principle that I said at the beginning. Detention should be a measure of last resort and exceptional in all circumstances. But the deliberation 11 on health emergencies states that this threshold is particularly high in this situation of public emergency, because it should then be even more of a measure of last resort, and it should be even more exceptional, the detention of migrants in this context. That's it for deliberation number 11. If I still have a few minutes, I would like to move to deliberation number 5, because it's also relevant to the issue of migrants more in particular, and also it's still relevant for the issue of COVID-19, for the current pandemic. So in brief, with just a minute left, I'm going to say that deliberation number 5 repeats that the prohibition of arbitrary detention is absolute, that seeking asylum is not a crime, so it's a right. So the exercise of rights should not be criminalized. Therefore, seeking asylum or refuge should not be deemed as a criminal offense. Also, as Professor González said earlier, deliberation number 5 repeats the key principle that children detention is prohibited and children should not be detained in the context of migration. Then when states need to resort to detention, it is important, deliberation number 5 says that when there is detention of migrants, it should be ordered by a judge. It should be subject to periodic review, and the individual deprived of liberty should have the right to challenge the legality of that detention. Not only that, the individual should also be granted or guarantee the right to be informed of the reasons for that detention. It needs to be justified under the individual circumstances of that person. It should not be punitive in nature, and it should be for the shortest period of time possible. Now, also, when states decide to detain a person in the context of migration, the period of detention must be set and must be informed to the person for that detention not to become arbitrary. And as a consequence also, to guarantee the right to challenge the legality of such deprivation of liberty, the state needs to guarantee access to legal representation, but also to, in the case of migrants, to consulate representation and access to the consular authorities of that migrant. Finally, and obviously, those migrants under immigration detention should be treated humanly with respect to their dignity, and also should be provided, therefore, medical care, and migrants should not be held or detained in police stations, should not be held or detained in prisons or remand facilities. That is because for the detention not to be punitive in nature, it should take place in a separate facility than those for individuals within the criminal justice system. As for the question about the good practices, I would say very obviously the release of individuals, either early release, conditional release, or temporary release is a good practice. Also, before imposing the measure of deprivation of liberty, the consideration of alternatives to detention is another good practice that should be encouraged. And then access to interpretation services of those migrants deprived of their liberty, as well as facilitation or facilitate communication with family and lawyers of those migrants deprived of their liberty is another good practice that should be encouraged. Thank you so much.
Thank you very much, Francisco, for sharing more about the work of the United Nations Working Group on Arbitrary Detentions and these key considerations during health emergencies, such as the COVID-19 pandemic, which are also very important for the overall legal framework of the right to liberty and security of migrants, among others, in the face of deprivation of liberty in the context of migration. Now, the realization, promotion, and protection of human rights is mostly seen on the ground. That is, the extent that all people everywhere, regardless of their legal status, are and can enjoy and fulfill their human rights, also in times of emergencies. Let's further zoom down into local level responses to the COVID emergency for migrant populations carried out by civil society in Switzerland by Doctors Without Borders, and in the border region migration hotspot of Colombia and Venezuela by the Asociación Salto Ángel, a diaspora migrant-led NGO based in Colombia. Roberta, what actions and initiatives has Doctors Without Borders developed and implemented to respond to the COVID emergency for the protection of migrant populations in Switzerland? What have been some of the challenges faced and solutions designed during this time? Over to you, Roberta. Thank you.
Thank you very much for the invitation, and thank you to all the participants for being here. I'm sharing the presentation, so please let me know if you can follow it, if you can see it. Is it okay, Gianna? Yes, okay, thank you very much. So I would like to start this presentation by doing a little bit of a mapping of what MSF is doing on the field related to migrants and COVID. However, this is a bit of a challenging exercise because most of our projects somehow, even in regular times, deal with people on the move, in the broader definition. And right now, during the pandemic, most of our projects, if not all, deal to some extent with COVID. So I put some resources if people want to read more, but I will give a very quick snapshot of some of the activities that we are running. Some of them are related to direct COVID response. Regarding migrants, for example, we are supporting migrants, Mexican migrants that are deported from the US and that have no capacity to be in quarantine, on isolation, or even to access healthcare when they come back to their own countries. In communities where the COVID is not spread yet, we support health services for COVID preparedness. This is particularly challenging in places where the population is precarious, like refugee camp in Tanzania, but everywhere in the world. But the COVID preparedness is an activity we are doing almost everywhere. One of the big challenges for us is also to maintain the capacity of our regular activity, maintain capacity to access health services, specifically related to migration. As an example, in our nutritional treatment center in the south of Niger, most of our beneficiaries come from Nigeria. And right now that the nutritional season is starting, the border is closed. So we are trying to bring healthcare to them as they cannot come to us. We also work a lot on advocacy to make sure that what we are discussing today basically is pushed from different sides. So as you can imagine, we are talking about many different contexts, but still we can highlight some common issues. So these people tend to live in precarious environments, living in harsh, often unhygienic and overcrowded conditions. They have a limited access to healthcare, limited capacity to protect themselves, their close ones and the communities, because they have limited capacity to stay home and self-isolate. This obviously applies to extreme contexts such as refugee camp. We can imagine the condition in Greece, in Bangladesh, or in general in refugee camp. But as we will see, it also applies to the rich city of Geneva, where some migrant population face the same challenges. So a little bit of context regarding Geneva. It's one of the richest cities in the world, very international, very multicultural. It has a health system that is based on private insurance. Of course, all the country has a very strong health system and social system. In Geneva particularly, but a bit of everywhere in Switzerland, there is an unknown number of documented migrants. The particularity here is that most of these people have been living here for very long, sometimes for decades, so are somehow integrated. They have their own coping mechanism, and they mainly work in those contexts that have been badly affected by confinement related to COVID. So relatively high, we don't know how much, but part of them lost their job and their income with important consequences that we will highlight later on. Anyway, given this little bit of context, people might wonder what MSF is doing in Geneva. And that's what we wonder also at the very beginning, but actually we realized that there are quite a lot of activities to run. I will divide them in main pillars because we did quite a lot. Pillar number one was to make sure that we could reinforce the local institution and association that were already in regular time providing services for this vulnerable population, but they were facing constraints related to all the measures that they had to put in place to provide the same services under safe conditions for the beneficiaries and for their own volunteers and employees. So we work on logistics, hygiene, general organization of the service, and this reassured them very much in the way they could continue to provide these services. We also did quite a lot of health promotion and information on COVID. In the country, the messages have been spread widely. They were very clear, but we mainly tried to adjust those messages to the specific needs. For example, saying you need to go and get tested if you are symptomatic, but even if you are an undocumented migrant, you can be tested even for free and you will not be reported. And this was a very important message to us. We also made sure that we could make available a team of doctors and nurses that could provide home-based care, including testing, for free to people without health insurance. These were services that were already available for the general population, but as you can imagine, very expensive. Just to give you an idea, a COVID test in Geneva is about between $300 and $500, so hard to afford for many people without insurance. Pillar 4 was COVID case management and contact tracing in shelters for homeless people, most of which were migrants, because again, they faced fear to go to the public service to get tested and to get treated, but also because despite the fact that in the general population, contact tracing was stopped because we had too many cases to be able to follow. We thought that it was very important to do contact tracing in this context to avoid further spreading of the disease in shelters where condition and overcrowd was a bit of the rule. On top, of course, of the health promotion and hygiene measures. Pillar number 5, quite tough to imagine, but in Geneva, there was a big food distribution that was launched by several associations that MSF supported, especially in terms of logistics, distributing more, sorry, the sign is wrong, than 16 food boxes in less than 2 months. We also took the amazing opportunity to try to uncover the needs of this part of the marginalized population that are not very well described or were not very well described. So we didn't know who these people were, what were their medical needs, accommodation, and food insecurity. And we provided the service to the people coming to food distribution. So statistically, this cannot be applied to the general population, but still give us a big insight on what is happening after the beginning of the outbreak and the confinement measures. So in general, we found out, and this data regards specifically migrants, undocumented migrants, there is reduced access to healthcare. This is, of course, in generally true. 90% of them had no health insurance, but there was also 5% that had health insurance before, but could not pay the fee anymore. Higher incidence of COVID, 4.5 versus 1% of the general population. People were unlikely to get tested if symptomatic because of economic issues. They could not isolate or stay in quarantine. Some of them faced difficulties in pay rent and some lost accommodation, and important food insecurity, with 70% of them reduced the quality and quantity of food, 20% had to skip meals, 6% spent entire days without eating. And this is in rich Geneva. The sixth and last pillar was about advocacy. So again, we worked very closely with local institutions and with associations to widely spread the results of these services and what we were seeing on the field to make sure that these needs were addressed. There was a big political commitment. The COVID test today is for free in Geneva, and there is a discussion to make it free in the rest of the country. And there is a discussion on regularization of undocumented migrants for this specific pandemic. So I will go quickly as I'm running out of time, and these points have been discussed broadly by my colleagues. So what can we do to protect migrants? We must make sure that COVID is not used as an excuse to enforce deadly migration and control policies, ensure that human rights are respected, make sure that lockdowns and quarantine are not just discriminatory used for this population. Displaced people at risk should be evacuated whenever possible. Let's think, for example, about Greece and the camps in the islands, and need to safeguard the access for healthcare for all. Thank you very much.
Thank you so much, Roberta, for sharing with us what is happening back in Geneva and how Doctors Without Borders is active not only in Geneva, but all around the world to provide protection for the rights of migrant populations. Now, last but not least, we have a migrant-led diaspora NGO based in Colombia in the border with Venezuela, providing constant support to the human rights of Venezuelan migrants, not only in the COVID times, but always. And here with us is Andrés Boscán. He is the vice president of this association that is growing as we speak. And they have created a video just for this session to show you guys what action they have been taking on the ground to respond to the COVID emergency to the Venezuelan migrant populations. Andrés, ¿te gustaría decir algo o vamos directamente al video? Te doy la palabra, Andrés. Gracias.
Hi, everyone. Bueno, agradecido, Gianna, con el espacio y por permitirnos visibilizar las acciones que desde la sociedad civil hemos iniciado para atender una emergencia en el marco de otra emergencia. La frontera colombo-venezolana sin duda presenta problemas críticos a nivel socioeconómico y desde la organización intentamos aliviar un poco las necesidades y la precariedad con la que se vive en la región. Entonces, eso es lo que quisimos visibilizar con este video, que más adelante estaremos compartiendo con la traducción en el inglés en YouTube.
Gracias, Andrés. Well, I'm going to translate quite quickly. So Andrés, he just mentioned that they're active on the ground, basically trying to deal with one emergency, which is indeed the Venezuelan migrant flow from Venezuela to Colombia, the hottest spot for migration for the Venezuelan migrant population, on top of another emergency, which is now the COVID health emergency. So they've provided a video for us, which I will be sharing now. And the video has both English and Spanish text. It's a 7-minute video. I've shared it in your screen chats. I will put it up here, but I don't know if the audio will be heard, but I will try it. If not, you can open it in your screen. Just 1 minute. In the meantime, if you have questions, please send them to me via the chat, and we will get to some depending on the time in the end of this presentation. So I'm gonna share my screen with you all.
Mi nombre es Andrés Boscán, soy periodista, migrante venezolano y actual vicepresidente de la Asociación Salto Ángel, una organización civil sin fines de lucro que desde el eje fronterizo de La Guajira, en Colombia, trabaja en la implementación de proyectos y servicios orientados al fortalecimiento de procesos de desarrollo social y de vida digna del individuo, con el objetivo de transformar situaciones de vulnerabilidad en oportunidades de integración, inclusión, desarrollo sostenible y restitución de derechos. En medio de la emergencia sanitaria por COVID-19, nuestra misión en la gestión de derechos ha crecido de manera exponencial en aspectos como salud, protección, orientación legal y asistencia humanitaria. También ha aumentado nuestra capacidad de articulación con la cooperación internacional y entes del Estado. Cabe destacar que La Guajira posee un índice de pobreza multidimensional del 51.4%. Solo el 39.5% de la población tiene acceso a agua potable y el trabajo informal supera el 90.3%. Ante el escenario aún más complejo por el inicio del confinamiento, nuestra primera acción fue poner a disposición nuestras líneas de atención y orientación por vía WhatsApp. La implementación de un plan estratégico de comunicación en redes sociales y comunidades virtuales que brindara oportunidades para el acceso a la información a la población migrante. El objetivo era unirnos a los cables informativos de las instituciones del Estado y mitigar la infodemia, así como contrarrestar las narrativas xenofóbicas y aporofóbicas de la opinión pública alimentadas muchas veces por los medios locales. La población necesitaba estar informada sobre las medidas tomadas por el gobierno colombiano, los riesgos de salud pública y las medidas de autocuidado. Justamente en los municipios de Maicao y Riohacha se dieron hechos de alteración del orden público en la que se vieron involucrados los migrantes. Ya no bastó con brindar información, por lo que se iniciaron procesos de caracterización, focalización y acompañamiento a la población migrante para brindar asistencia humanitaria. Esto representó un desafío para nuestra organización con limitantes operativas y escasos recursos financieros. En los hogares migrantes empezó a faltar alimento, aumentó el riesgo de desalojo por incumplimiento en el pago de la vivienda, se acentuó la necesidad de acceso a servicios de salud y medicamentos y la conectividad para la educación en entornos virtuales de los niños y jóvenes y la comunicación con sus familias en Venezuela. Además de las carencias por no contar con insumos de bioseguridad, higiene y saneamiento. Sin embargo, logramos construir un programa de asistencia humanitaria con 4 componentes: alimentación, higiene y saneamiento, promoción del autocuidado emocional y mitigación del riesgo del desalojo. Salto Ángel es miembro fundador de la Coalición por Venezuela, una plataforma que reúne a 63 organizaciones de la sociedad civil en 23 países del hemisferio y que tiene bajo su enfoque la crisis migratoria venezolana. En Colombia es representada en 25 de los 32 departamentos. Esta iniciativa cuenta con el reconocimiento de la Organización de Estados Americanos y ello ha permitido establecer una comunicación directa con las instituciones del Estado y sus gobiernos. El ejercicio de incidencia permitió que se asignaran a La Guajira 32.000 kits de alimentos dirigidos a población migrante en articulación con entes territoriales, cuerpos de emergencia, fuerza pública y la sociedad civil organizada. De esto, la Asociación Salto Ángel logró hacer entrega del 8% de bolsas de alimentos, equivalentes a 6.283, sumándose al operativo como un músculo adicional. También se constituyó una sala de monitoreo para la focalización de familias a través de líderes barriales y la conformación de una brigada de emergencia capacitada para minimizar los riesgos de contagio por COVID-19. La amplia experiencia en gestión de derechos y el reconocimiento ante la cooperación internacional permitió fortalecer los procesos internos con dotación de insumos de bioseguridad, subvenciones telefónicas y de conectividad, artículos de higiene y saneamiento para la operatividad de las respuestas con aliados como PNUD, OIM y FUPAP. En esto también jugó un rol fundamental la sociedad civil, que hizo aportes económicos y en especies cercanos a los $550. Pero el ejercicio no quedó allí. A través de la cooperación internacional nos convertimos en aliados estratégicos de respuesta. Con ACNUR logramos activar rutas de protección para 32 familias. Con Mercy Corps referenciamos 104 familias en riesgo de desalojo para recibir el dinero en efectivo para el pago de arriendo. A través de Médicos Sin Fronteras recibimos 225 kits de higiene y 56 colchonetas para la atención de caminantes migrantes en proceso de retorno a Venezuela y asentamientos informales. Con el Consejo Noruego para Refugiados iniciamos entregas de 200 kits de higiene para mujeres. Pero esto no es todo. El sector privado también se ha unido al programa. En convenio con Advocacy y Fundación Éxito se están haciendo entrega de 48.000 kits de higiene a nivel nacional. Con empresas del sector y recibimos cargamentos de alimentos y artículos de higiene que han permitido beneficiar a 122 familias migrantes de privado. Continuamos trabajando en la activación de rutas de protección en cuanto a género, infancia, vivienda, apoyo psicosocial, ayuda contra el suicidio y gestión de riesgos de salud. La pandemia ha evidenciado las brechas sociales y económicas en las comunidades de acogida de la población migrante retornada. La reciente evaluación de necesidades de la población migrante en el contexto de COVID-19, elaborado por el Grupo Interagencial de Flujos Migratorios Mixtos en Colombia, indica que el 54% no posee ninguna fuente de ingreso. El 8% de sus hogares tienen problemas de convivencia con episodios de violencia basada en género y violencia contra los menores relacionadas al confinamiento. El 30% no tiene acceso a la educación y un 58% no puede acceder a la salud. Es importante reconocer los esfuerzos de los gobiernos de la región en la implementación de acciones y políticas públicas que abriguen a la población proveniente de Venezuela. La Coalición por Venezuela, en compañía de la OEA, ha presentado un documento con el ánimo de ayudar a las naciones a alcanzar soluciones comunes y pertinentes ante los desafíos. Estas recomendaciones apuntan a crear espacios de salud y centros médicos en lugares de mayor concentración de población migrante y permitir su acceso a atención médica a pesar de su condición migratoria. Realizar un censo de los migrantes en edad escolar que se encuentren fuera del sistema educativo para diseñar estrategias de inclusión y formación. Fomentar programas y becas con fondos que permitan la inclusión de jóvenes y adultos migrantes a la educación superior. Estimular la empleabilidad con incentivos administrativos y tributarios para impulsar la contratación de migrantes. Desarrollar programas y campañas contra la estigmatización de la población irregular. Prohibir desahucios de familias, niños, niñas, adolescentes, adultos mayores y mujeres embarazadas durante la pandemia. Diseñar programas sociales de apoyo que permitan proporcionar alimentos a las poblaciones vulnerables. Fomentar mecanismos de regularización de los migrantes y refugiados para que puedan acceder y participar en la economía formal. Crear un fondo económico para la protección del derecho a la vivienda de los migrantes y refugiados, especialmente de las familias más vulnerables. Para la Asociación Salto Ángel la tarea continúa y seguimos trabajando en procesos de fortalecimiento organizacional, ampliando nuestra presencia en el territorio, sumando voluntades a nuestra misión y convirtiéndonos en referente de emprendimiento social.
So I hope you were able to read the text in the video. If not, if you were able to open it also on your web so you can hear the video. Anyways, you have the video there. I hope you were able to understand some of the actions that Asociación Salto Ángel is carrying out to respond not only to the Venezuelan migrant population emergency in Colombia, but now with this COVID emergency as well. And it was nice to see that in the presentation, they also partner with Doctors Without Borders for the provision of kits, of health kits. So here we are connecting the worlds, how collaboration and cooperation really make a difference on the ground as we saw today. So I have already a few questions here on the line. And one of the most important hot topics as we see in the human rights world is how can we expand the principle of non-refoulement, the principle of non-return, thanks to the human rights law framework, to go beyond refugee populations. Perhaps, Rohini, if you want to say a couple words, and then Special Rapporteur Felipe, I can also give you the floor as well to explain rather quickly in a minute or so how the human rights law framework could expand the non-refoulement principle to protect migrant populations beyond just refugees. Over to you, Rohini, and then to Felipe.
I think just a very quick comment there is indeed, I think we need to see the expansion of the principle of non-refoulement beyond refugees. As we see in today's world, we are increasingly looking at mixed population movements, and the lines are definitely getting blurred between, you know, refugee movements and other migratory movements. So, I mean, this is something I think we also have been working together with IOM in certain countries, where we work together with a mixed population movements. But I think for the legalities, I would probably leave it to the Special Rapporteur to elaborate more. Thank you.
Thank you for the question. Well, this is an issue that my mandate has been addressing with many states. In the communications that we send to states, we stress that for migrants in general, and and not only for refugees or asylum seekers, this is a valid principle. This is based more generally in the Convention Against Torture and on the interpretation also of a number of international instruments of human rights law. In fact, this was a matter of hot discussion during the negotiations of the Global Compact on Migration. And although the principle of non-refoulement is not explicitly mentioned in the Global Compact on Migration, its main features are there in the compact. And for the human rights bodies, regardless of the regulations in the Global Compact on Migration, this is a matter that has been already settled. So as I said, we have been raising this repeatedly to many states around the world.
Thank you very much, Rohini and Felipe. Would anyone else like to add something? Professor Zard, please go ahead.
Yes, I just to add to what's been said, and the potential of the Convention Against Torture to really provide very strong supplementary relief to the conceptualization of non-refoulement in traditional refugee law. And there have been, you know, a limited, very small, limited number of cases which have looked at issues of healthcare in the context of the definition of cruel, inhuman, and degrading treatment. And found that in certain limited instances, the return of someone, for example, with HIV to a place where they would be separated from family that they would have left behind in the country they'd been living in, to inadequate access to healthcare in the place they were being returned to, given the stage of the disease that they were experiencing, would rise to the level of you know, CIDT and torture under the Torture Convention. So there are these limited openings which have been created. And I think one of the things that will be really important to explore, particularly as we see return in the context of this pandemic, is how we can open up that understanding a little bit more and really think about the guidance that has been given by some of these universal bodies around CIDT and torture, and expand it to include people beyond you know, traditionally defined refugees.
If I may, Gianna, very short. The Inter-American Commission has an interesting case about the United States on this matter. The Andrea Morlock case, which was a Jamaican citizen who had lived in the US for 20 years or so, and was HIV positive in an advanced stage, and it wasn't sure that she would get good healthcare in Jamaica. And the Commission stated that their return, their deportation would be in violation of the American Declaration on the Rights of Duties of Men. The U.S. in the end suspended the deportation of Mrs. Morlock.
Thank you so much for sharing these additional insights. I just want to add that this is a question that our workshop participants have been discussing in our virtual workshop on migration and human rights, and I've provided them a list of resources that talks about these human rights principles to expand on that framework, that the refugee framework and the protection of migrant populations beyond the refugees to seek asylum, and the principle of non-refoulement. And I know that the United Nations Human Rights Office will be publishing a publication very soon exactly on this topic. How does the human rights law framework expand this definition, as including the principles that were mentioned by the experts today? So I'm just gonna share with you some of these resources in the chat so everyone can have access to. And I have a second question as well. So it was said by the Special Rapporteur that it is important to protect the rights of the migrants in the host countries, and it is equally important to successfully reintegrate them in their countries of origin upon return. So there's a question from a participant here regarding the key principles of human rights to consider while designing reintegration programs for returnee migrants. So what are the key principles of human rights to consider in the design of reintegration programs when migrants are returned? So who would like to take that question? Perhaps Felipe, Professor Monette, or Rohini?
Well, I may say something. I don't want to take all the questions, but very briefly, I think that there is a point I have observed in a number of countries, which is the lack of a gender perspective in the reintegration programs. And this is especially grave considering that migrant women returning to our countries of origin are many times subject of stigmatization, especially in traditional societies. So it's very important to have a social programs in place and economic support for them to adequately reintegrate. This in addition to other aspects, but I don't want to speak too much. Gianna, está sin micrófono.
Ah, vale, gracias. No, that we are eager to hear from the experts during this moment, during this space here connected with you. So if you can just share some of the key human rights principles regarding reintegration of returning migrants, anyone really, we'd appreciate this opportunity to hear you. Panelists? No? Too hard of a question for you?
No, I mean, I think this is such a multifaceted question, if you don't mind. And I find myself thinking about this, with you all on here. I do think that one of the issues that's come up very powerfully in some of the work that we've done is that migrants are being sent back having been denied the opportunity to, receive wages for work that they have done in countries that they have been living in, the processes that they have been put through in order to be returned under the pandemic have really denied them access to all kinds of due process, with respect to the lives that they were living and the resources they left behind. So that is a peculiarity, I think, of the way that returns have been managed in the COVID pandemic, which has raised particular challenges. And I know Migrant Forum Asia, for example, has been raising this issue of unpaid wages as a critical concern that migrants who have been returned have been raising. And it's perhaps not something we generally think about, but it's certainly something that should be factored into how returns are managed and the speed with which they're happening, quite apart from the health consequences.
So related perhaps to this, there's another question. How can we differentiate between relocation of migrants for public health reasons and relocation for political purposes, since we see some governments acting perhaps not within the framework of human rights, within the principles that we've heard in terms of necessity, proportionality. How could we sort of distinguish this action in terms of moving migrants from houses to another, from a center to another? And perhaps how could civil society or other actors react when these situations happen? Anyone?
I don't want to monopolize the floor, so if there are others who would like to say something, please go ahead. I do think that these have to be case-by-case examinations, and the science matters, the public health basis matters. And so I don't think, you know, we can necessarily say that there are broad rules to follow, except to look in great detail at how these relocations are happening and those principles around necessity, proportionality, and the public health rationale for what is being done. And I agree that there are some real difficulties, not just around relocation, but for example, a big issue right now is this question of shielding. One of the ways in which refugee camps, for example, might be protected from the outbreak of COVID that is happening in the host population, you know, the idea of shielding the refugee camp has been floated as one possible strategy of basically, you know, treating the camp as one self-contained zone and controlling who goes in and who goes out. And what's interesting is, depending on where you are, that conception is received very differently by refugees. So in Uganda and in Kenya, refugee groups themselves have been saying, you know, there might be something through this shielding idea. We believe it might protect us. And so listening to their voices is absolutely critical. But then when you look at how shielding is playing out in other places, for example, in the MENA region, and the context there is very different, and controls around freedom of movement that predated COVID, and the relationship between the host government and the refugee population was very different. And so shielding there is being received in a very different way. So not only looking at these case by case and examining each of these criteria and the science and public health rationale in great detail, but also listening to what the refugee population is actually telling you. I think that's really critical.
Concerning not refugees, but migrants, undocumented migrants, this has been problematic in some countries. For instance, in Malaysia, this is an issue that I addressed in some communication to a state and made public through a press release. The government has taken advantage of the COVID-19 lockdown to target the migrant population who are at their homes, many of them, and so they make raids and I take them to other places, mostly to places of detention. So this may not be relocation in the same way that was asked, but it is getting a group of migrants, a large group of migrants, and conducting policies that are not being applied to the national to the nationals in the country. So that's really problematic.
Thank you very much. Andrés, tengo una pregunta para ti. I have a question for you. It concerns the indigenous Wayuu population between Venezuela and Colombia. La población Wayuu desplazada indígena en la región de Colombia y Venezuela ha sido obviamente también afectada no solo por la emergencia de migración venezolana y en Colombia, pero también por la emergencia de COVID. ¿Ustedes trabajan para responder a esta emergencia con las poblaciones indígenas Wayuu en particular, o saben de alguna iniciativa que también pueda responder a esta emergencia de COVID con esta población Wayuu? ¿Te puedo ayudar a traducir luego? ¿Interpretación o vas por el inglés? Como quieras, Andrés, te doy la palabra.
Bueno, en respuesta, sí atendemos población Wayuu. Conocemos muy de cerca el caso, hacemos presencia en el municipio de Uribia, que es el territorio donde más concentra población Wayuu y donde hay asentamientos, digamos, muy autóctonos en estas rancherías donde ellos suelen vivir. Hemos atendido a la población indígena. De hecho, el día de mañana tenemos una entrega de kits de higiene en esa zona, y en articulación con la alcaldía municipal vamos también como a llevar camiones de agua, porque el acceso al agua potable en esa zona es casi que nula. De hecho, el gobierno colombiano lo que implementó en el territorio fue la prohibición a estos resguardos indígenas de cualquier tipo de población, y de hecho hasta la ayuda humanitaria le ha costado como ingresar a la zona, porque los permisos necesarios no pueden ingresar al territorio.
A ver, voy a traducir rápidamente. Yes, Asociación Salto Ángel also assists and services the indigenous population Wayuu, mainly in the Uribia region, which is the region where this population is most concentrated. And in fact, they've been already providing assistance even during the COVID emergency. And tomorrow they'll be going to provide them with some hygiene and health kits, as well as with water trucks in cooperation with other partners and the municipality, because this region has difficulty in accessing clean and potable water. So they will also support with the access to water. And he's explained that this region, because it's autochthonous indigenous region, and there are some restrictions related to that area, it's difficult at times for humanitarian aid to reach these populations. ¿Te gustaría adicionar algo más, Andrés? ¿O eso era todo? Como quieras, ¿eh?
No, ya será todo.
Gracias. Rohini, I know you mentioned that maybe you would have some examples perhaps to share during this time. Would you like to share anything else based on your very interesting presentation of UNHCR?
You're muted, Rohini.
Sorry. Is that better now?
Yes.
Yeah. Also, just to before I do share a few of the examples, to go back to the question of relocation and the point made by my co-panelist on the shielding in refugee camps, or the idea of relocation. I mean, for example, I mean, the situation in Bangladesh with the Rohingyas, during the COVID pandemic, I mean, the restrictions and the lockdown has been lifted now by the government, but there was a period in time where we were not able to access the refugee population, It was, I mean, the reason given was also to you know, control the movements of the refugees outside the camps. But also there is the government perceives the situation of the Rohingyas as a temporary situation. And therefore, you know, all the measures that it takes is again, you have to see the motivation behind it. There was an idea of also fencing the camp at some point. It hasn't gone through yet. There's also increased security around the camps. It also raises protection issues, issues of accessing the refugee population. The other, some of the Rohingyas who were found at sea were also transferred to the Basan Char Island, relocated there from Cox's Bazar. I mean, they never came back to Cox's Bazar. Again, the reason being given was that, you know, they wanted to make sure that they were not infected and would not then spread the infection. We have always been advising the government that it is not a secure place. It's a cyclone-prone island. And again, negotiations are ongoing with the government for us to have access to that island to then check the conditions of the people and to meet them and to see what concerns they have there and how long they're going to be held there. So yeah, it's just the point that I wanted to make in terms of relocating refugees.
Thank you very much. Did you have any other example regarding your presentation, or am I mistaken?
Regarding, I think it was basically I had a few of the examples just to highlight, you know, our interventions that we have been making in Asia, and I mean, mostly it has been to sort of address critical protection activities, and for us to be innovative in approaching, I mean, where we cannot be physically present, to use other methods to continue to monitor and protect populations of concern. And communication with refugees and internally displaced is something that has been of concern to us. And we've been trying to find various ways, you know, of expanded networks, internet platforms, hotlines, call centers, to still be in touch with the refugees and the displaced populations. Conducting remote case management activities, you know, remote registrations, interviews, refugee status determinations, resettlement interviews as well. Trying to sort of find a safe space where documents can be shared securely. Also engaging the community structures and, you know, present within the refugee camps in identifying and responding to protection issues, and not just protection, but health-related issues as well. You know, using these community volunteers, health workers to identify health issues, to build awareness, to also, you know, the point about you know, the stigmatization of you know, being tested or you know, trying to address those issues, giving referrals for medical treatments, etc. So I mean, this is what I wanted to say was that I mean, our mantra has been to stay and to deliver during the pandemic as well, but wherever we can't, then we're trying to find other remote ways of still staying and delivering.
Thank you so much. Dear panelists, if you have anything else to add, this is your chance. If not, I will thank you and we can close. So over to you in case you have anything else to add. Now is the chance. No? Well, without further ado, I give you a big and warm thank you to the experts who contributed to this very interesting panel. And thank you to all the participants who connected. We had over 140 something, maybe 150 participants connected worldwide. So thank you very much. And yeah, perhaps see you on the next webinar. Have a great day wherever you are, and do stay safe and healthy, and continue working for the protection and the promotion of the human rights of migrants all around the world. Thank you so much for everybody.
Thanks a lot to you, Gianna. And thanks to everybody.
Thank you, Roberta. Thank you.
Thank you, Gianna.
Thank you, everybody.
Gracias, Felipe. De nada. Gracias, Francisco.
Thank you. Thank you,
Thank
Gianna.
you, Rohini. Thank you.
Thank you, everyone.
Gracias, Andrés.
Good
Thank you,
afternoon.
Monette. Good afternoon. Thank you so much.